quick because we have 2 more speakers and I don't want to cut on their time. So thank you very much again, Elder. So we now come to our next speaker. This is Professor Matilu Mwao from Kenya. Is he here? Dr. Mwao. He's not. I thought it's him, no, but... Well, so what we do is we just skip him, and in case he shows up later, before we finish the session, then he still can talk at the end. So then, in this case, our next speaker is Dr. Paula Melariri. She is from South Africa. She works for the famous institute, the CSIR, the Council for Scientific and Industrial Research. She's a pharmacologist, and she's talking about the bioavailability enhancement of tafenoquine. This is an anti-malarial using nanoparticles as drug delivery system.
Hi everyone. I'll be talking on the topic that says nanomedicine and malaria treatment. Basically, I'll be speaking on what we've done in the unit. And not everything actually, just going to be specific because of the time. And I'm going to go through this, the background, treatment challenges and nanomedicine, potentials, tafenoquine precisely. Then I'll present some of the results we've got, the PK results, and the in vitro and in vivo results. Sorry. Okay. 4 species basically infect humans. The P. falciparum, P. vivax, and P. ovale, as well as Plasmodium malaria. But of late, Plasmodium knowlesi has also been incriminated. But then it's basically affecting monkeys, but we've seen cases reported that it affects humans as well. We've talked about this in Professor Xavier's presentation. He gave this slide as well, showing us the 3 basic life cycles. You can see the part that takes place in the insect, the one that takes place in the liver, and in the red blood cells. And actually, all these need to be holistically targeted to ensure, complete elimination. But at the moment, we are working on getting targets, to the liver, to the blood, and the interesting talk he was talking about for the mosquito is also an aspect we are looking at. But the result I'm presenting today is going to be on the drug aspect of it. Basically, 627,000 malaria deaths are recorded worldwide annually, and 90% of these deaths occur in sub-Saharan Africa. And it's disheartening to know that 77% of these deaths actually occur in children less than 5 years age. And a child, as you're saying, dies of malaria every minute. Severe malaria actually can kill within 24 hours if adequate treatment is not given. And a lot of people, up to 3.4 billion, are at risk. And the risk individuals include these children we're talking about, pregnant women, migrant workers, or those on tourism in endemic countries. So if you take a look at this chart here, you will see the emphasis, the 95.1 in Africa, and that's the deaths, and the cases actually is also huge in Africa. Sorry. Okay, we have different types of drugs, to treat malaria. The problem is that these drugs have some limitations. They have some shortcomings, because in the market, I know we do have the ones that act in the blood phases, the one that acts, in the liver phases, and even the ones that actually can target both phases, the blood and the liver. But the problem is that there are certain limitations which these drugs have shown currently. And also, bearing in mind that there's no vaccine yet that could be used to treat the disease. So it's actually a bit of problem to treat this disease at the moment based on these limitations. Just like you can see in the next slide, we have poor absorption of some of these drugs, poor bioavailability, the drug not being present at the right concentration required for a therapeutic dose. And also we have toxicity in some of the drugs and poor patient compliance, probably because of the repeated dose and dose frequency. So the truth is that we have some presentations that nanomedicine could actually help alleviate some of these problems. It has the ability to increase the half-life and increase the solubility, targeted delivery, and a lot that we have seen in this talk. So I'll quickly go to tafenoquine, which is one of the drugs we've worked on. It's an aminophenolene, which is actually a good drug. It has a long half-life. It has a potential for radical cure, and is also effective against the different stages we saw in the life cycle. But we have a huge concern, especially with G6PD deficient individuals. It's not advisable to take these 8 aminoquinolines, including primaquine, and the rest of them, and it's also poorly bioavailable. So we actually started working on this drug. We did the in vitro study. We actually formulated a microemulsion of tafenoquine. And with this emulsion, we were able to get the sizes quite low, less than 25 nanometers range. And when we did the in vitro analysis, we saw that there was basically a slight increase. Okay, if you look at the data there, you will see that this is the free tafenoquine in this row, and then this is the micro tafenoquine. That's our formulation. And you can see that there's really no significant change when you look at the two in the in vitro assay with the sensitive strain. But when you look at the strain, the DD2, which is the resistant strain, we actually see a bit of difference. But then we always know that the in vitro results may not really be what you extrapolate to depict the in vivo state. Hence, we proceeded to do the in vivo work using this group of mice, and we collected the blubber, the tail, and the administration was bioaverage. And when we did the administration of the nano emulsion and compared it with that of the free tafenoquine, we saw actually that there was an increase in blood concentration over the range of time we can see there. Then we also went ahead to analyze the PK parameters, and we saw that actually if you look at the dark values there, they are the free tafenoquine. The free tafenoquine, the red values are the tafenoquine in our emulsion. We looked at the Cmax, the Tmax, the apparent half-life, the AUC, as well as the bioavailability, and we were able to see that for the Cmax, there was really it's not significant. The change is not significant, but there was an increase. We also looked at the Tmax, the apparent half-life. There was also a little increase in the half-life, but then we saw that there was a significant increase in the AUC, and that actually could explain why the bioavailability was enhanced from 55% to 99%, and we can see the standard deviation there. So when we saw this result, it was really interesting, but we needed to still bear in mind, of course, one of the problems of the drug. Remember I mentioned it earlier, that of toxicity, especially with G6PD deficient individuals. So we have that at the back of our mind. We actually decided to do an in vivo work to know the efficacy of this of the free drug compared to the formulation. And when we did this, we saw that at concentrations 1 milligram per kilogram, 5 milligram per kilogram, and 10 milligram per kilogram, we were able to see changes, which could actually speak to the AUC, which we observed in the PK evaluation. And we did a PK/PD study to really know if at the state of infection, because remember the previous was on uninfected mice, but at the state of infection, what is it like? So we saw that actually when it's infected, we also noticed a huge change in the AUC. So the free drug at 1 milligram per kilogram showed an enhancement, a significant enhancement in the efficacy in infected mice. And these mice were actually allowed to develop parastemia before the single dose treatment was administered. And we looked at this and we felt it's exciting, but then we needed to explain to ourselves, to convince ourselves why do we think this emulsion was more bioavailable? What could be the reason? So we decided to, assay a kind of the different excipients we have, and we noticed that the solubility was actually much more pronounced in the full microemulsion with all the excipients. And when we looked at this, we said, okay, the next phase is to do an evaluation using the skid mice model with humanized red blood cells, which we don't have access to, but my company had to kind of sign an NDA with Upstate University, the Upstate Medical School, and we did the GCPD evaluation. The results are not presented here. So we're happy to see that the differences we've noticed in our formulation in the PK and the efficacy also correlates well with what we saw in the initial preliminary results from Upstate Medical School. And we also saw that the percentage loss of the humanized red blood cells was also not increased in our formulation. And the interesting thing is, when we compare the preliminary results we have and the efficacy data we have from the work in affected mice, we could really see that we were able, with the formulation, to enhance the efficacy without actually increasing the toxicity. So that was really interesting, and we felt like we are here not just to present these results, because, yeah, we know that we have really appreciated the fact that nanomedicine can really enhance treatments, but we also want to know, just like Professor Zavis mentioned during his presentation, yes, what is the next step? How do you take it further from here? So in the question time, I also want someone to address that as part of our questions. Thank you very much.
Thank you very much for this nice talk. We have time for some questions.
Thank you, Paula, for your talk. I have a double question. What did the microemulsion contain? And if you think it can be used also for other drugs besides tafenoquine?
Yeah, actually, we use different excipients, surfactants, and non-ionic surfactants. We use FDA-approved polymers like PLGA, PEG. We actually even twin, like you can see there, some of the excipients are there. So we also know that it could be used for other drugs. I mean, we can use it for other antimalarials, but we've not really investigated that on other antimalarials. We were using the spray drying method for other antimalarials as well.
No more questions?
I have a question, please, basically to Xavier. You said something during your presentation. You said... You're not supposed to. I thought one person would ask since... you said something, please, during your presentation. I'm sure it would be a good idea to hear it from you. You said when you developed that method, you spoke to the farmer and they guided you that it's going to be elaborate and all that. So maybe, like I mentioned to you, I would like you to please probably maybe throw more light on how, at this stage, how you can approach a pharmaceutical company, or how you can, really seek that advice from them, or the contacts or something like that, whatever approach you use.
I mean with your model?
Okay, you can use it as a case study.
No, I think if you have something that works, and especially if it's not very expensive, I think you should go straight to them and present what you have, because they are always economy minded. Then if you have something that works but it's expensive, they probably will not buy it for malaria. That is something we have suffering in our flesh, because one of the conditions for the existence of our small unit is that we patent things, and when they put us this objective in our way, I ask them, are you sure that this is sensitive to patent things for malaria, when probably the companies who might be interested, they will want to make a profit. Then, obviously, I confirm this later when talking to different pharma industries. And then I think your model might be very good because, in my opinion, a microemulsion is something which is cost-effective. It will be not expensive. Then if you show this improvement in efficacy, I think that's why also I made my second question. You could maybe try to show that it works as well with other drugs. And then if you have something that works with different drugs and which shows, well, you probably have to do first your pharmacology, like looking at the stability of this microemulsion, different temperatures, especially high temperatures, shelf, half-life, and with all these things, when you have some little evidence, I would go directly to any pharma company that maybe it's based in South Africa, which might be easier for you, starting from there, and just try.
Thank you very much.